Here at Crossroads Hotel, where the Pharmacy and Medicines Regulatory Board have a press briefing regarding the research that they have had on Malawi, talking about the highest proportion of poor quality medicines. Now, one of the core objectives of this board is to have quality controlled testing of medicines and allied substances. We're here to hear more about this study and also what does it mean for the country. My name is Priscilla Kairansani. I'll hand it over to the board as they start this event.
Good morning, ladies and gentlemen. Welcome to Crossroads Hotel in the capital city, Lilongwe, where the Pharmacy and Medicines Regulatory Authority, PMRA, has a message to the general public, and we would want to communicate that message through our colleagues from the media. So before we start our press briefing, may I invite a volunteer to give us an opening prayer. Any volunteer, please. Yes, Sarah. Thank you very much. Tikutero kuti tikulandileni kuno ku Crossroads Hotel mu mzinda wa Lilongwe, kumene bungwe la Pharmacy and Medicines Regulatory Authority PMRA likufuna lipereke uthenga kwa Malawi kuzera kwa anzathu amene timalemba komanso kuulutsa nkhani. Ndizindikire Director General PMRA, Mr. Mpaso Kawaye, komanso ma members executive management amene abwera nawo kuchokera ku PMRA. Tili ndi Mr. Kadewere, Godfrey Kadewere, kuchokera ku unduna wa zaumoyo, Ministry of Health. Welcome, sir. We have from Central Medical Stores Trust, Dr. Chikaiko Chazunda. Welcome, sir. The high table, members of the press, ladies and gentlemen, let me also, maybe in a special way, recognize Mr. Stambuli, Clement Stambuli, a concerned citizen. Thank you so much, sir, for joining us. Before we proceed, maybe it's important that at least the high table here knows which media houses are present. Can we quickly do a round of self-introductions? You mention your name and the media organization you are representing. Cholinga kusogolo kuno aziwe kuti kodi ndi nyumba ziti zowulutsa mawu zimene zili mchipinda chino. Mwina tiyambire mbaliyo.
Good morning, my name is Emmanuel from Malawi.
Zikomo kwambiri ndiye mwina mwa changu ndingokuoneseraninso amene ali kutsogolo kuno akuluakulu athu amene akhale akulankhula ndi mtundu wa Malawi kuzera kwa ife amene timalemba komanso kulusa nkhani. Ndiyambire kumapeto uko kumeneko tili ndi Dr. Chazunda kuchokera ku Central Medical Stores Trust. Thank you very much. Pachiwiripo tili ndi Mrs. Chris Chulu amene akuchokera ku bungwe la Pharmacy and Medicines Regulatory Authority PMRA. Kenako tili ndi Director General a PMRA Mr. Mpaso Kawai.
Good morning.
Kenako tili ndi Mr. Steve Chapima amene ndi mkulu wa department ya laboratory kumene amayeza mankhwala ku PMRA.
Good morning.
Kenaka tili ndi Mr. Godfrey Kadewere kuchokera ku Ministry of Health.
Good morning all.
So the way we are going to proceed, we will have the Director General of PMRA to read a statement which PMRA has prepared, through which it wants to communicate to the general public in respect to the issue that I should believe we are all aware of. There was an article by the Guardian newspaper of the UK which quoted a study, or I should call it a review, by Bahar Dar University of Ethiopia, where Malawi was singled out as having one of the highest prevalence of substandard and falsified medicines in Africa. Apparently, that study also made a reference to another study which was done by a Malawian researcher here in Malawi. Of course, the study was done at the University of Ghana in 2015. So there are a number of issues around this particular subject matter which the authority would want to clarify. Ndiye Director General akamaliza kuwerenga statement imeneyi, imene tikunena kuti bungwe la PMRA lufuna liyankhepo pa nkhani imene mwina ambiri tikuidziwa. Newspaper ya ku UK ku England idasindikiza posachedwa apa kunena kuti ku Malawi mankhwala ambiri aku Malawi ni mankhwala amene samafikira mulingo wake woyenera. Ndiye pali zambiri zimene bungwe limene la PMRA lufuna lirambasule mogwirizana ndi nkhani imeneyi. Akamaliza kuwerenga statement imeneyi mchingerezi, tizape mphaso Mrs. Chulu kuti awerenge statement yomweyo mchichewa kupangira zathu amene mwina chingerezi sangamve kuti uthengawu uwafikire. So reaching that far, let me invite the Director General of PMRA, Mr. Mpaso Kawai, to say a few words and thereafter proceed to read a statement which Pharmacy and Medicines Regulatory Authority has prepared for this press conference. DG.
Distinguished members of the press, fellow Malawians listening to this press briefing wherever you are, all protocols observed, good morning. You are all very welcome to this press briefing where we want to have a candid discussion on matters surrounding quality of medicines, especially in relation to a recent paper that was published that reports that Malawi is one of the countries with the highest prevalence of substandard and falsified medicines in Africa. We will begin with reading the statement, and it reads, PMRI's statement on the study claiming Malawi has highest prevalence of substandard and falsified medicines. The Pharmacy and Medicines Regulatory Authority wishes to inform stakeholders and the general public that it is aware of the article published in the Guardian newspaper of 4th August 2024 titled, Fifth of Medicines in Africa may be subpar or fake, research finds, end of quote. The article cites a study by researchers at Ethiopia's Bahir Dar University, which suggests that Malawi has one of the highest prevalence of substandard and falsified medicines in Africa. The Bahir Dar University review, which analyzed published studies between 2014 and 2024 from different countries in Africa, referenced a 2015 study by a Malawian researcher at the University of Ghana, who in his study reported that Malawi had 88.4% prevalence of poor quality anti-malarial medicines. Accordingly, the authority examined the referenced 2015 Malawi study, which is the sole source of the claims in question, and would like to state as follows. 1. The study which the article quoted only examined the quality of anti-malarial medicines which were La, quinine, SP, DHA, DHAP, and others. This means that the findings of the study cannot be used to generalize the quality of all medicine in Malawi, as portrayed by the Bahir Dar University review. 2. Based on the design of the referenced 2015 Malawi study, the samples were drawn from the private retail pharmacies, private clinics, and private medicine stores. The study did not include samples from the government health facilities, which constitute the largest proportion of anti-malarial medicines consumed in the country, and also whose brands are not found in the private sector. This study, therefore, cannot be used to generalize the quality of all anti-malarial medicines used in the country. 3. The laboratory analytical method used for assessing La in the 2015 reference study was modified from a published, well-validated method. However, the extent of the modification was quite significant and resulted into inferior validation parameters, rendering the method unsuitable for assessing quality of La. For example, from the same batch of La gave significantly different results, which is not normal in medicines analysis, especially considering that the samples were collected from regulated facilities. 4. Therefore, the failure rate of La, which was 95% in the study, which had the highest number of samples, 41 out of 112 in the 2015 study, was largely due to analytical method problems. Had the analysis been done as per the reference analytical method, which was done by Arun in 2011, the failure rate could have been much different from 88.4%. That was reported in the 2015 Malawi study. Additionally, 36% of all sample results were outside the validated linear range, and therefore should not have been used to establish the quality of antimalarial medicines in this study. This is because the results that fall outside a validated linear range are inaccurate, imprecise, and unreliable. Furthermore, PMRA would like to inform the public that its medicines quality control laboratory is ISO 17025 accredited. The accreditation means that Malawi has the requisite capacity and international recognition to test and assure quality of medicines which are consumed in the country. Using this ISO 17025 accredited laboratory, PMRA tests medicines samples, among others, prior to distribution to the facilities, and also those samples collected through routine quality surveillance activities. Results from routine quality surveillance activities over the past 4 years indicate that the prevalence of substandard medicines in the country is currently at around 4%. The World Health Organization estimates that on average, 10.5% of all medicines in low to middle income countries are substandard or falsified. Recent studies in the country have reported findings consistent with this WHO estimate. It must also be pointed out that the prevalence of substandard and falsified products in any country is related to the strengths of the regulation of the supply chain pipeline of medicines. In Malawi, regulation of the supply chain pipeline, starting from where medicines are manufactured to a point where they are consumed by the client, is clearly within the scope of PMRA's mandate. It is a regulatory requirement under the PMRA Act of 2019 for any medicine that gets imported into the country to be produced by a manufacturing company that has been inspected and licensed for compliance to WHO Good Manufacturing Practice Standard. The medicines coming from the licensed manufacturers have to be quality assessed and also registered on a list of registered medicines for Malawi before they are authorized for use on the Malawi market. Also, only registered pharmaceutical wholesalers, for example, the Central Medical Stores Trust and other private wholesalers, are allowed to import medicines directly from the manufacturers through a PMRA-issued import permit, and that is used by customs for clearance at port of entry or at the borders. In March 2023, the WHO conducted the regulatory benchmarking assessment for the medicines regulatory system in Malawi. The results of the assessment in relation to medicine supply chain security indicated that PMRA has documented procedures necessary to grant authorization for medicines importation and distribution activities that are also well implemented. The assessment also indicated that a rapid alert system for managing the threat of substandard and falsified medicines and for recalling these products from the market is implemented too. Finally, The authority acknowledges the importance of studies conducted by institutions of higher learning, whose recommendations inform public health policy and medicine's regulatory practice. However, the authority calls on adherence to best research practices, as incorrectly done studies may raise alarm and grossly mislead the public to lose confidence in the health sector. Further, such studies undermine the efforts by government institutions, partners, and stakeholders in the health sector in ensuring access to quality health services. To this end, the authority will continue to engage with research institutions to harness collective expertise, drive research-informed regulatory decisions, and ultimately ensure the safety, efficacy, and quality of medicines for the benefit of all Malawians. The authority assures stakeholders and the general public that the country has the capacity to undertake medicine quality assessments for product registration, and also the capacity to monitor quality of medicines on the market. I thank you for your attention.
DG pakali pano nditane Madamu Chris Chulu kuti atipasile statement yomweyo komano mchichewa. Madam, please.
Zikomo kwambiri. Ulemu kwa adindo onse amene muli pano, anzathu ena nonse komanso ndi Amalawi onse kumene ali. Pemala ili pano kuyankhapo pakafukufuku yemwe akuti ku dziko la Malawi kwachuluka mankhwala osafikira mlingo woyenera. Bungwe la Pharmacy and Medicines Regulatory Authority PMRA likudziwitsa anthu onse kuti likudziwa za nkhani yomwe newspaper ya The Guardian ya ku Mangalande inasindikiza pa 4 August 2024 ponena kuti mankhwala ambiri kwa Africa kuphatikizapo dziko la Malawi ndosafikira mulingo woyenera. Newspaper iyi idagwira zotsatira zakafukufuku yemwe sukulu ya ukachenjede ya Bahir Dar ya ku Ethiopia inachita, zomwe amati ku dziko la Malawi ndikomwe vutoli lakula kwambiri. Ochita kafukufuku apa sukuluyi adaoneka zotsatira zakafukufuku osiyanasiyana okuza mankhwala wapakati pa zaka za 2014 ndi 2024 kuphatikizapo kafukufuku yemwe nzika ina ya kuno kwathu idachita mchaka cha 2015 pa sukulu ya ukachenjede ya Ghana. Zotsatira za kafukufuku wa nzika ya ku Malawiyu zidaonetsa kuti pa nthawiyo mchaka cha 2015 vuto la mankhwala osafikira mulingo linali lalikulu kwambiri limene lili 88.4%. Bungwe la PMRA launika bwino lomwe kafukufuku wa 2015 yemwe sukulu ya Bahir Dar yagwiritsa ntchito mu ripoti lake, ndipo bungweli likufuna liyankhepo motere. Choyamba, kafukufuku yemwe newspaper ya The Guardian komanso sukulu ya Bahir Dar idagwiritsa ntchito amene ndi kafukufuku wa 2015 anali kafukufuku yemwe pa nthawiyo ankaunika mankhwala amalungo monga la quinini, SP ndi ena. Izi zikutanthauza kuti zotsatira za kafukufuku wotere sizingagwiritsidwe ntchito kufotokozera ubwino kapena kuipa kwa mankhwala onse kuno ku Malawi, monga momwe sukulu ya Bahir Dar ya Bahida ikunenera mu ripoti lake. Chachiwiri, mankhwala omwe adagwiritsa ntchito pakafukufuku wa 2015 anawatenga ku mafamasi, zipatala zazing'ono zomwe sizaboma ndi malo ena ogulitsira mankhwala. Kafukufukuyu sadatenge mankhwala kuchokera ku zipatala zaboma komwe kuli mankhwala ambiri amalungo omwe mitundu yake simapezeka ku zipatala zaboma, komwe kuli mankhwala ambiri amalungo omwe mitundu yake simapezeka ku zipatala za anthu ndi malo ena ogulitsira mankhwala omwe si aboma. Pachifukwa ichi sikunali kuyenera kuti zotsatira za kafukufuku wotere azigwiritse ntchito kufotokozera ubwino kapena kuyipa kwa mankhwala onse amalungo kuno ku Malawi. Chachitatu, ndondomeko yoyezera mankhwala yomwe adagwiritsa ntchito mu kafukufuku wa 2015 adayisintha poyerekeza ndi ndondomeko yoyezera mankhwala yokhazikika ndi yodziwika bwino. Ndipo kusinthaku kunali kwakukulu zomwe zidapangitsa kuti ndondomekoyi ikhale yosayenera kuyezera mankhwala amalungo monga mwachitsanzo, mankhwala anambala ya chizindikiro chofanana amatha kutulutsa zotsatira zosiyana zomwe zinali zodabwitsa potengera kuti mankhwala amukafukufukuyi adawatenga kumalo ovomerezeka kusunga mankhwala. Choncho titha kunena kuti mankhwala ala omwe chiwerengero chawo chinali chambiri mukafukufukuyi adalephera kamba kakuti ndondomeko yoyezera mankhwalayi sinali yabwino. Tili ndi chikhulupiriro kuti ochita kafukufuku wa 2015 iyo akadagwiritsa ntchito ndondomeko yabwino yoyezera mankhwala sakadapeza kuti chiwerengero cholephera cha mankhwalawa chinali 88.4%. monga momwe ananenera mu ripoti lawo pa nthawiyo. Chachisanu, kuonjezera apo 36% ya zotsatira za kafukufukuyi zinali kunja kwa muyeso wovomerezeka wopezera zotsatira za kafukufuku wa mtunduwu, ndipo sizimayenera kugwiritsidwa ntchito kupeza ngati mankhwala amalungo amukafukufukuyi anali abwino kapena ayi. Bungwe la PMRA likuziwitsa anthu onse kuti malo a bungweli oyesera mankhwala a National Medicine Quality Control Laboratory ndovomerezeka ndi bungwe la International Organization for Standardization ISO. Izi zikutanthauza kuti dziko la Malawi lili ndi kuthekera ndi ukadaulo okwanira kuyeza ndi kutsimikiza ubwino wa mankhwala omwe anthu amagwiritsa ntchito mdziko muno. Bungwe la PMRA limagwiritsa ntchito laboratory yovomerezekayi poyesa mankhwala lisanapereke chilolezo kuti mankhwalawo afike pa msika, komanso kuyesa mankhwala omwe akugwiritsidwa kale ntchito ndi cholinga chofuna kulondoloza kuti mankhwalawo akadalibe abwino. Zotsatira za bungweli pa ndondomeko yake yolondoloza kuti mankhwala omwe anthu akugwiritsa ntchito ndi abwino akusonyeza kuti mu zaka zinayi zapitazi chiwerengero cha mankhwala osafikira mulingo woyenera chili pa 4%. Bungwe la zaumoyo la pa dziko lonse la World Health Organization WHO limati 10.5% ya mankhwala maiko osauka amakhala osafikira mulingo woyenera kapena achinyengo. Kafukufuku wina waposachedwa mdziko muno akugwirizana ndi ripoti la bungwe la WHO. Anthu akuyeneranso kudziwa kuti vuto la mankhwala osafikira mulingo kapena achinyengo mu dziko lililonse limatengera kukhwima kapena kufoka kwa malamulo komanso mfundo zomwe dzikolo likutsata kuchoka kumene mankhwala akupangidwa kukafika kumene anthu akugwiritsa ntchito mankhwalawo. Kuno kwathu ndi udindo wa bungwe la PMRA kuonesetsa kuti malamulo okhudza mankhwalawa akutsatidwa. malinga ndi malamulo athu oyendetsera nkhani za mankhwala a PMRI Act 2019, mankhwala omwe amabwera mdziko muno kuchoka maiko akunja amayenera akhale okhawo omwe apangidwa ndi kampani zokhazo zomwe bungwe la PMRI laziyendera, komanso kuti zili ndi chiphaso chosonyeza kuti zikutsatira ndondomeko zabwino zopangira mankhwala za bungwe la WHO. Mankhwala awa akafika kuno ku Malawi amayenera kuti ayezedwe asanalembedwe mukaundula wa mankhwala wa bungwe la PMRI ndi kupatsidwa chilolezo chakuti atha kuyamba kupezeka pa msika. Makampani okhawo omwe ali mukaundula monga Central Medical Stores Trust CMST ndi makampani ena omwe si aboma ndi ololedwa kuyitanisa mankhwala kuchokera ku makampani opanga mankhwala, ndipo amayenera akhale ndi chiphaso choyitanitsira mankhwala cha PMRI chomwe chimagwiritsidwa ntchito mzipata zolowera mdziko muno ngati chilolezo cholowetsera mankhwala. Mwezi wa March 2023 bungwe la WHO lidayendera bungwe la PMRI mwazina ndi cholinga chofuna kuona momwe dziko la Malawi limaonetsetsera kuti ndondomeko zoonetsetsa kuti mankhwala omwe akubwera mdziko muno ndi abwino zikutsatiridwa. Bungwe la WHO lidapeza kuti dziko la Malawi lili ndi mfundo zosindikizidwa zabwino zothandiza kuchepetsa vuto la mankhwala osafikira mulingo. Bungweli lidapezanso kuti dziko la Malawi lili ndi ndondomeko zabwino zochotsera pansika mankhwala amene apezeka kuti ndi osafikira mulingo woyenera. Pomaliza, bungwe la PMRI limazindikira kufunika kwa kafukufuku yomwe sukulu za ukachenjede zimachita popeza zotsatira za kafukufuku otere zimathandizira kukhazikitsa mfundo zabwino za ntchito ya zaumoyo komanso mankhwala. Komabe, bungweli likupempha onse omwe amachita kafukufuku kuti azitsatira mfundo zabwino za kafukufuku, chifukwa kafukufuku opangidwa mosasamala amazitsa mantha pakati pa anthu, komanso amapangisa kuti anthu ataye chikhulupiriro chawo ndi nthambi ya zaumoyo. Konjezera apo, kafukufuku otere amachepesa ntchito zomwe nthambi za boma, mabungwe ndi ena akugwira ntchito poonetsetsa kuti anthu akupeza mankhwala omwe ndi abwino, otetezeka komanso ogwira ntchito bwino. Pa chifukwa ichi, bungwe la PMRI lipitirira kugwira ntchito limodzi ndi sukulu za ukachenjede ndi cholinga chopitisa patsogolo ukadaulo pa ntchito za kafukufuku wa mankhwala zomwe zili ndi kuthekera kothandizira ntchito za mankhwala kuti zizipindulira anthu onse. Bungweli likutsimikizira anthu onse kuti asataye mtima chifukwa dziko la Malawi lili ndi kuthekera komanso kadaulo oyesera mankhwala asanayambe kugwiritsidwa ntchito, komanso kulondoloza ngati mankhwalawo sakupereka chiopsezo kwa anthu. Zikomo kwambiri pakumvetsera kwanu.
Zikomo kwambiri, madam. Mwina tisanapereke mpata kwanza tu olemba komanso kulusa nkhani kuti tifunse mafunso. Ndiwalole Director General kuti mwina atha kukhala ndi mawu pang'ono onjezera komanso mwina atha kupereka mpata kwa ena kuno kutsogolo kuti atha kuyankhula ziwiri zitatu. DG.
Thank you. Just to add a few points of clarification before we proceed further into this conversation. One is that the Ethiopian Baha'i Dar University did not actually collect samples from Malawi. And they did not actually pick the samples to test them at their laboratory. No. The approach they used was to look online and find studies that have already been done in over 20 countries in Africa. Look at the results and compare the results of of substandard and falsified medicines in the countries that they recruited in their study. That is why, if you look at the press statement, the approach that is being used is we are interrogating much the study that was done in 2015 in Malawi, because it is the study that was recruited, whose results were used by Ethiopian Bahada University. Secondly, I just want to guide at how this press statement is structured. If you look at the press statement, the first part is in 3 parts. The first part is looking at the design of the study and what we consider an erroneous extrapolation to say that all medicines in Malawi are falsified and substandard quality, and also all medicines in the entire country are falsified and substandard. It also extends antimalarials to all medicines, which is also an error. In the second part, we are actually interrogating the methodology that was used in the laboratory to find that Malawi has the highest proportion of substandard and falsified medicines. You will see that because of the scientific nature of the subject, we have a special information sheet for those with special interest to look at the details of this analysis. But otherwise, we've put across our summary and the conclusions that we make from the analysis that we make on the method that was used. What is major on the method is the observation that the method that was used was modified from the original method that was supposed to be used to assess these products. The modification was significant, and the one that modified was unable to demonstrate that his method is similar to the method that originally should have been used to measure the quality of these products. The final part is looking at, we are giving you a picture of how secure our medicine supply pipeline is. So we are putting across the process that we do in ensuring that we do not get medicines that are of substandard quality and also that are falsified. Thank you.
Thank you very much, DG. The floor is now open for questions. Yes. So, just a moment. So what will happen, we'll take the first round of 3 questions. You raise a hand, we'll give you a mic. You reintroduce yourself and the media house you are representing, and then ask your question. Tikutelo kuti titsegula bwaloli kuti tifunse mafunso, ndiye mutchula zina lanu, nyumba yaulisira mawu imene mukuyimirira, kenaka mufunsa funso lanu. Komano mwina tisanambe kufunsa mafunso, ndaona pali dzanja kumbuyoko, mwina titapereka maiki kumeneko. Tigwiritse ntchito microphone.
Clement Stambuli ndabwera muno ngati nzika yokhudzidwa, ndiponso amene ndinalemba kalata kwa aspika kuwapempha aspika kuti kudzera mu komiti zawo zoyenera aitane amene amayang'anira za mankhwala kuno ku Malawi kuti akhale nawo pansi afunsane, ndi akatha pamenepo auze mtundu wa Malawi mmene zinthu zimakhalira. Ndikhulupirira bungwe loyeneralo ndi limene labwerapo werali, koma ndikadakondwa kuti akadakhala kaye ndi aku parliamentiwo, chifukwa mwina pakanakhala ndondomeko zoti akanakhala ndi ma independent other bodies woti angathe kuthandizana kupanga analyze zina ndi zina before coming out. Komabe ndikuthokozeni kuti mwabwera. You have come out and to assure Malawi mmene zinthu zilili. Ripoti yomwe dawerenga lomwe lidakhala ngati kupereka nthumanzi ndinali ripoti yomwe danena kuti ku Africa kuno pafupi anthu 500,000 amwalira chaka chilichonse chifukwa cha mankhwala osayenera komanso mankhwala amene wadanena kuti ali subpar. Ndiye nditalemba kalatayo ndinaona kuti no mwachitaso inu press conference ndinanota mwina mwayi ndomwewu nanenso ndibwere kuti ndikhalepo. Komano chimodzi chomwe ndaona nchonena kuti mwabwera ndi report lomwe lili true scientific. Inuyo ngati amene mmapanga zimenezi. Ndimayembekeza kuti inde report la scientific olibwera koma tikaona zinthu zopanga polisi zinthu ngakhale Malawi police kuti ithe kupeza zinthu zolakwika imathandizidwa ndi anthu amene ali pa ground. Kukhala ndi laboratory yabwino sikungasonyeze kuti m'midzi anthu azimwa mankhwala abwino koma kuti anthuwo azitha mukanatha kupereka zinthu zina chifukwa inuyo ngati regulatory authority ndikhulupirira muli ndi maumboni okwanira onena kuti mwapezapo mankhwala olakwika pa nsika. Sizingatheke kuti kuyambira 1988 kufika lero mankhwala onse amene abwera ku Malawi kuno palibe amene munalandapo. Mankhwala amene amatha kumagulitsidwa otapanga expire simmalanda chifukwa mankhwala olakwikawa akhudza ndena amene apanga expire. Timatha kupita kupeza kuti mankhwala ena ali expired ngakhale mu pharmacy koma akadali pa shelf. Ndiye ndimayembekeza kuti mupemphanso mtundu wa Malawi kuti no Amalawi ifeyo ngati bode yanu ndife ndi khomo lotsekuka. Mukaona pena pache kuti mwakayikira kuti mankhwala yawa si mankhwala abwino ife tili pa hotline iyi mudzitiuza chifukwa tikatero tithandizana. Koma kubwera kuno nkungotipatsa a scientific setup nkutisonyeza ngati kapena kuti chilichonse ku Malawi kuno chili bwino ndikuti kuti simuthandiza mtundu wa Malawi chifukwa inuyo mulipo anthu ochepa kwambiri. As an institution simungathe kupanga police ndi kupanga regulate zinthu zimenezi. Ndiye ndimafuna kuti no inuyo mutithandizepo. Chinanso chomwe mwanena nchonena kuti amene anapanga research they use secondary data. They did not go on the ground whether through the internet or they cited other researches that were done before. Chinthu china nchonena kuti inu mukudziwa ngati bode kuti mu 2015 Malawi wina anapanga research nkutulutsa research yomwe inali yolakwika mudali kuti nthawi yonseyi kuti musauze mtundu wa Malawi chifukwa institution yanu kaya you are citing the article the yaujeni ya 2017 koma inayamba 1988 kusonyeza kuti kuyambira kale kale mdziko muno mwakhala muli mavuto amenewa. Inapangidwa 1988 ntchito inayamba kugwira 1991 kusonyeza kuti inalipo ndipo iniyo munalipo. Nchifukwa chiyani pa 2015 simunabwere poyera nkumutenga munthu yo nkupanga assess my findings ache and put a clear record. You are coming in now. Chinanso chomwe ndifuna kuti niyo mudziwe nchonena kuti pakali panopo timatha kupita kukagula mankhwala amalungo kapena kulandira mankhwala amalungo nkumaliza dosage munthu malungo osatha osachira kusonyeza kuti mavutowo tili nawo. Koma vuto lathu Amalawi timangopanga safa mwachinsisi sitimatuluka nkudandaula. Ndiye mutithandize iniyo ngati institution kuti no mukhale ndi kuthekera kodzionetsa kwa Amalawi kuti ntchito yanu ndi iyi ndipo ngati mukaona zinthu zolakwika zotere muzitithandiza. Munomo musabwere ndi defensive approach mubwere ndi corrective approach yonena kuti ife tonse ngati Amalawi tithandizane kugwira ntchito imeneyi kuti no zinthu m'Malawi muno zikhale bwino chifukwa 20% achulayo it is across the African continent. Ndiye ma borders athu ali porous. Mankhwala ena muna malo ochoka ku Zambia ena malo ochoka ku Tanzania si mankhwala onse amene inu amapita ku laboratory kwanu. Ndipo zifukwa zimenezo ineyo ndabwera kunoko ngati mmodzi mwa Malawi okhudzidwa ndi cholinga choti tikonze zonsezi tonsefe ngati Amalawi, chifukwa vutoli ndilokhudza tonsefe. Mankhwala ambiri amene amamwedwa siwochokera ku chipatala cha boma. Anthu akapita ku zipatala za boma osati kuyambira dzulo, koma kwa zaka zambiri amauza kuti pitani mukagule mankhwala kuno kulibe. Ndeko ina makagula mankhwala nkumene kuti masampo amene wanatenga kuma pharmacy amene se aboma. Nkumene anthu Amalawi ambiri akupeza mankhwala. Zikomo kwambiri.
Dzina langa ndi Emmanuel Chikonso kuchokera ku MBC. Ndiyambire ndo amene amalizirapo kuti mzipatala zambiri makamaka kumene mwina Malawi amakhala kuti akatenga mankhwala kumakhala kuti ndi zipatala zimene sizabomazo. Kafukufukuyi adachitika muzipatala mukuti zimene sizabomazo. Kodi iniyo kafukufuku wanu waposa chedwapa mwachita liti? Mzipatala zimene sizabomazo zimene siza private sizori mwachita liti? Komanso mudakamba nkhani yokhudza mene mawerenga statement yanu mudakambako kuti pali mukuonetsetsa kuti maboda mathumu musakhale polasi kapena kutsekatseka mmenemo mmene nthawi zambiri mumathaso kugwiritsidwa ntchito kudutsira mankhwala omwe sovomerezeka kapena sabwino. Sitikudziwa kuti mwina muli kukayikiranso kuti makampani kapena nthambi zomwe mudazikhazikitsa kuti zizitha kubweretsa mankhwala mdziko muno ndizonso mwina zimene zikuthandizira kuti tidzikhala ndi mankhwala otere kupatula mankhwala amalungowa. Ripoti limene mwina kuti idapanga focus pamenepo zimene nthaza kuti ngakhalenso mankhwala ena atha kutheka kuti alinso mwina osavomerezeka kapena sali pa mulingo umene uli woyenera. Situdziwa kuti iniyo ngati bode imene idasankhidwa kuti mwina idzitha kuyang'anira zimenezi kafukufuku wanuyo mwachita liti? Funso langa kwambiri lagona pamenepo, inuyo mwachita liti? Komanso mukadakonda kuti mwina adzikuchitani involve mwakafukufuku amenewa zimene nthawi zambiri imene sizingathekenso yayi. Ndithere pamenepo. Zikomo kwambiri.
Titengelo maliza for the first round.
Dzina langa ndi Robert Chandirira kuchokera ku Blantyre Synod Radio. Funso langa ndilonena kuti munafotokozera kuti World Health Organization inapeza kafukufuku wawo kuti mdziko muno muli ndi 4% ya mankhwala amene mwina ali a substandard kapena osavomerezekawo. Komanso research imene yabwera mutifotokozera lero ikusonyeza kuti mdziko muno muli mankhwala amenewo a substandard. Kodi simukuona kuti mwina ndizoonadi kuti vuto lilipo ndithu la mankhwala osavomerezekalo? Komanso mwina ngati regulatory body kodi muchitepo zotani kutengera ndi chithunzithunzi chimene chikuonetsa kuti mwina vuto limenelo lilipo ndithu kupatula kuti mwina kafukufuku wawo masamples anatenga mzipatala za private osati za boma? Zikomo kwambiri.
Mwina tipereke mpata kuti mafunso amene afunsidwa komanso ndemanga zimene zaperekedwa ziyankhidwe. Thereafter we'll take another round of questions. If we can have the mic back.
Zikomo kwambiri pa mafunso anu amene akuonetsa chidwi choti mukufunitsitsa tikambirane komanso mumvetsetse kuti kodi chikuchitika nchani pa nkhani ya substandard ndi falsified medicines. Ndiyambire funso lomaliza lenileni ndi comment yawo. Also in relation to comment inanidwa earlier kuti we should not just be defensive. Vuto la substandard ndi falsified medicine ndi global issue. Kwa Africa kuno ndilovutitsitsa ndithu. Mena nenera mu third part ya statement tanena kuti WHO estimate ikunenera kuti low to middle income countries, at the chances that you have a falsified and substandard medicines is 10.5%. Chimene tikutsutsana nacho ife ndi figure imene inaperekedwa ya 88.4%. Kuti we are not this bad. Chifukwa tinakalowa ku method mu lab. Kuti kodi laboratory method yanda ayuza munthu ndi yotani. Tifesetseri kuti how did he come to 88.4? Because we would think tienu pambanga hang around a WHO average, which is for low to middle income countries. Recent study, Malawi kuno, the most recent one, goes up to about 14%, which is still hanging around 10.5% for WHO. If a city research per se, our mandate is not into research. We have a program that my inspectors are talking about my facilities. Kukatenga masample amankhwala. Kubweretsa kulabu kwathu and monda kana ije kulabu yathu in terms of wesa mankhwala it is certified. Don't see lab yokagitsa high. Based on information immediately nayo mu database mwathu on all samples that we have collected, like in this case the past 4 years, we are getting to a percent ya 4% as substandard products. In fact, based on the information yathu, problem yathu Malawi kuno ndiya substandard. Substandard would mean kuti product yomwe anayapanga register. Koma company bopanga sina kwanilitse mulingo wa mankhwala amene akuyenerera. Falsified ndekuti chinthucho ndi criminal intent. Sichupanga contain mankhwala amene okhala mowo koma deliberately. Information yathu kuonetsera vuto lathu ndila substandard products. Koma osati pa mulingo wa 88.4%. Information yathu kuonetsa 4%. WHO iona 10%. We should be hanging around these figures osati kupaka ku 88.4%. Now ndipite ku funso loyambirira lija, which was also more of a comment. Kuti tabweretsa kwambiri science in his opinion. Ifeso titaona agenda iyi itangotuka pepa tinadzo kuti ndi agenda ya science, it is scientific in nature. Actually, chifukwa chimene tinatenga these 2 weeks to come to you was not because sinazindikire pompo problem. Kodi science imene itipanga translate bwanji kuti anthu amve kuti zifukwa zimene study iyo lakuikira zifukwa zake izi ndizi. Ndi chifukwa chakenso mmene manena za parts a statement yathu yendanena kuti part 2 tikupanga interrogate kapena tikuonetsetsa method or njira imene Malawi anapanga study mu 2015 anagwiritsa ntchito kupeza malizatsi amene wawa. Nde method iyo tinaona kuti ikha ndi zina za science zambiri. Mu statement taika mu summary chabe komanda menda naye muje pali information sheet ya science yoti ngati munthu ukuona kuti ukhoza ufuna panga cross check ndi yena amene akudziwa za science imene iyi amukhoza tenga information sheet yathuyo fata limba ba details ama observations. Study iso ili online, get the study online, give it to somebody who can interpret these things, cross checking what the study says against my observations atu. Koma clearly this study is scientific, taisetsa kuti ipange bring down kuti aliyese amve ma reasons amene study ili yolakwikira. Mwanenaso mu comment muja kuti PMRA ndika organization kukuchepa sitingakhale pali pose zimene zili zoona. Koma just to clarify that at the PMRA operates as a secretariat, so tilini ma collaboration ni ma organization ambiri aboma. For example, tima collaborate ndi police. Ku police actually kuli section ya drugs, just collaborating with us. That's what those police people do in that section, and they have contact people kumaboma ndekuti in terms of collaboration, in terms of kuti sitingafike palipose, in terms of kuti ndife ochepa, yes ndi ochepa, kwa ma collaborations athu ndamene amatithandiza. Tilinso ndi ma collaborations abwino kwambiri ndi Malawi Revenue Authority, Department ya Customs. Chifukwa ndi pamene timapangira clear mankhwala kubwera mdziko muno. Pa clearing ya mankhwala apa ndipezeronso mwayi opanga address comment ina imene amanena kuti tikupanga chani kuti ma substandard ndi falsified medicines akhale mu dziko. Mu pati yomaliza ya statement iyo tanena kuti the law, the PMRA Act, what it provides for is kuti aliyese amene amachita manufacture mankhwala for Malawi market akhale kuti has been inspected and akwaniritsa what we call WHO's good manufacturing practice standard. Iye uchatika mpanga license amabweza panga register mankhwala ake aja imodzi. Then we have a team that assesses the quality ya mankhwala iliyonse. So every medicine you see in pharmacy, you see in drugstore has been assessed and ngandipana kupatsana mafunso ndi manufacturer ayo mpaka we are convinced kuti quality yake libwino ikozokhala pa market. Product jega khala pa market, now munthu chafuna pange business azioda kandi kunja, for example ku India. Sangangopita kwa order for product yade panga register I no panga request ku PMRA ndi list ya ma product mwe panga register mwe panga sense I want to import. The PMRA will issue what we call import permit. It will list all those products. It will be signed akanma copies. What this permit is saying is you are not going to get this product from Dar es Salaam, for example, even when it is registered. This product will only be obtained from the manufacturer in India using a registered wholesaler in Malawi. So tilima private wholesalers ambiri, tiliso ndiya public Central Medical Stores Trust. For your own information, Central Medical Stores Trust has to register kutizibanga import mankhwala. So we have to look at their list also, confirm kuti their products are registered. So in doing so, we are trying to make the supply chain pipeline secure. It's only the manufacturer that can send directly to Malawi through this agent, which is a registered wholesaler, who will in turn sell to retail pharmacies, medicine stores, or kuzipatala. So this is the way how it is arranged. The risk we have is, that's why we think the risk is minimal. It is those that can come through smuggle, for example. Even that route, we tend to check. That is exactly why and to amenwagula mankhwala ku known facilities, because they'll be tapping on medicines through the secure route. Timapita ma retail, ma pharmacies, ma inspections, kukaona ma records za procurement also. So we are sure that our regulated entities should be buying from that pipeline. And also, the states also buy from alternative suppliers other than those that are registered by PMRA, which will be medicine stores that are registered, retail pharmacies that are registered, that are supplied by a registered wholesaler. Thank you.
So Wambiri Nonse and Sinangandina Godfrey Gadwere from Ministry of Health. And from Ministry of Health, I think first we thank you, Honorable Stambuli, for expressing the concern on behalf of all Malawians. We also take note that indeed in your concern you did actually express it directly to the Speaker of Parliament. And our coming here today and actually maybe engaging in the press conference is not really to replace the duty of the Parliament to call for a meeting. But more also, I think, following your concern, sir, there was also so many reactions from general public that it was also thought that, given the way the reactions are, it is also good to give assurances through the PMRA. And PMRA here is because it's also their duty to engage stakeholders, sir. like the media. And our engagement this day also shows that definitely there's been a gap in the engagement, which has got to be corrected, because some of the questions that are being asked today could have been avoided. So that, I think, we urge Malawians to also give an apology, and it has to be corrected through PMRA, that these particular engagements have got to be regular. Going back, you did express the concern, sir. So first, indeed, the PMRA has got a duty to react first based on what prompted the concern. So the concern was prompted by a study. So there has to be a reaction to the study. So more or so, yes, they've said it scientifically because the study is also on scientific basis, and their answer is also on a scientific basis. It's not to confuse anybody, but there's no better way of doing it. We are here because indeed we have a challenge, and indeed a problem exists. A problem of falsified and substandard medicines exists. That's why PMRA was created. Without that problem, PMRA would not be here, because we'll be saying medicines are manufactured, and therefore they come in circulation, everybody grabs it. So PMRA is here to actually contain that problem. I go back again. The lack of regular engagements puts us on the spot like nothing is being done. But so much is being done. So let's go back, sir, where you started. 1988, this particular organization was called Pharmacy, Medicines and Poisons Board. We're here today. It's being called the Pharmacy and Medicines Regulatory Authority. There is a change because even government is reacting to a change. So it is what is called today because we wanted to do a job better. What was happening in 1988 is not what is happening in 1924 or 2024. Indeed so. The press statement has made reference to a study of 1915. It's a long time back, sir. And indeed so, this university from Ethiopia, they have also based their reaction and their actual analysis on the very same study to quote for Malawi. There's been a very big time lapse, so I'll jump. There was a question from NBC, has there been recent studies done? I'll say yes, through QS they've done, and they've also really said that Malawi is not really the worst in the pack on medicines. If anything, Malawi is one of the countries that have got maybe good medicines in circulation. So that is an assurance, and like I said, it will be corrected as we have more regular engagements as we go into the future, but basically that has got to be noted. So our coming was one to actually really also say that indeed we have a problem, so much is being done, we have room for improvement. Why do we have room for improvement? The statement also consists that the circulation of substandard and falsified medicines is indeed a global issue. And every government has got a responsibility to contain that problem, including Malawi. So the PMRA with the other enforcement agencies have a duty to actually really do it and contain it for Malawi, that lives are not put at stake. As I also agree with you, sir, that the availability of falsified and substandard medicines do lead to many undesirable consequences. Loss of money, prolonged illnesses, and in worst case scenarios, loss of lives. We have to avoid that. And that's definitely the duty of the PMRA to contain the problem and actually avoid those problems that Malawi does not face the same handicaps. But indeed so. Even coming from the Ministry of Health, I will agree that the problem of falsified and substandard medicines circulation, as it would be, is a global problem. It spares no country for many reasons. One reason is what you also cited, sir, that porous borders already give a problem. So long as we have porous borders, even the system that the PMRA is painting can actually be circumvented, and it does get circumvented. We can also see that one evidence is most of the cosmetics we have on the market. Most of them, they are illegal, but they are on the market. They are not going through the PMRA. It's actually coming through porous borders. We have to do more. Like I've said, indeed, the problem is so big, the capacity cannot really contain it, the more reason they engage other enforcement agencies to work with them. So what am I saying? I'm saying indeed, if we appear to be defensive, that's not our wish. Our wish was really to engage with you, to actually really explain about the study and give assurances that Malawi is doing a lot as far as medicines are concerned, that there should be good quality medicines. But definitely there is a room for improvement, that there has to be no falsified or substandard medicine circulating. And that again also needs at least some responsibility from every Malawian to report anything that we think is not really fitting in for us to actually have good medicines on the market. I think that's where I would actually start. I would also want to wish that maybe medical stores can actually comment at this early stage. Can you comment, sir? Thank you.
Thank you so much. As the DG has already said, we are part really of the supply chain for the nation, and I would like to assure the nation here that as Central Medical Stores, we are very serious with issues of quality control of medicines. And we have a specific section for that. And how we do it is like this. The first thing, as the Director General said, we are not supposed to stock any medicines which have not been registered by PMRA. That's the first thing. So that process starts from tenders. When we give out tenders, advertise in there, you actually see there would be a statement that suppliers should only tender for products which have been registered by PMRA. That's the first thing. The second thing is that when products have come, despite that they were already registered, we actually take samples of batches and we send them to PMRA for testing. So only products which have passed the test at PMRA are those products which are made available for distribution to hospitals. And indeed, from our records, from 2020 to 2021 period up to this year, the average failure of products from the tests done at PMI has been 3%, indicating that we are quite fine. Like for this year, is actually the pass rate is 99%. So from that, the public has to be assured that whatever we provide to the public hospitals, there are medicines which are not substandard. There are medicines which are not falsified. In addition to that, as CMST, we are going further to complement the efforts of PMRA. We are putting in an in-house lab for testing medicines. Actually, we've just identified the supplier. So, really, from our own side, maybe that's why the results which were based on samples picked outside the public health system gave possibly those funny results based on a desk study. Basically, they did a desk study. And with things like those which are very sensitive, they did not try to triangulate the evidence. Because when you are doing that research, very sensitive research, you need to do triangulation of evidence. You can't just make pronouncements based on desktop study. So, really, from Central Medical Stores, the nation should be assured. As regards quality, we're on top of it. And even we are very vigilant regarding arrests, which possibly sometimes, some of you might have noted that WHO would give arrests regarding some products which are not fit for human consumption. Fortunately, for the past year, all the arrests did not involve any products which we also stopped. And we have vigorous procedures, standard operating procedures regarding, sometimes even when products have gone out to the market, maybe because of storage conditions, they would possibly start having some issues. We have a vigorous standard operating procedures for recalling products. And you would find that the experience we have with very low percentage of recalled products, actually less than 1%. Thank you.
Zikomo kwambiri. Mwina titenge last round of 3 questions. Yes, Nation.
Thank you so much. My name is Suzio Chitete from Nation Publications Limited. Bwana Moderator, I hope it won't be the last round. I mean, it will be a missed opportunity if you don't give maximum opportunity to members of the press. My first question goes to PMRA. I'm happy to be here because the last time when I sent a questionnaire to PMRA highlighting the studies from KUHES, you were at pains to accept the findings that indicated prevalence rate of 14%. And of course, antibiotics, I think, were the worst in that list. You, for lack of a better word, you discredited the findings based on the sample size, 23 health centers against 1,000 plus. You also had problems with the lab. Here you are referencing to the same study. Of course, it's Minister of Health that has talked about KUHES, but I would understand when you said studies done here are showing a much lower prevalence, you could be referring to the KUHES studies. Have you finally come to terms that this study can actually be trusted? That's my first question. The second one is a twin question to PMRA and Central Medical Stores. I want to seek understanding in terms of how you pass these samples or indeed these batches, just to understand the process. Maybe for purposes of accountability, I'm looking at some of the recalled medicines based on statements that I have seen from worldwide pharmaceuticals distributors. I think 13 April 2023, there was another one, Intermed, Artemis. All these ones have been recalling products last year. If you need the evidence, I can actually provide to you through email or WhatsApp. When they are recalling these products, what happens to the test that you do before products go on the market? Should we be questioning the testing, or there is chance for error? I just want to come very clear on that one. And when you do the tests, let's say the batch has failed at that particular point, what happened to accountability, just to instill a sense of trust in the public, where you invite members of the media and you would say this has failed from supplier B and this is the action that we are taking? I'm not so sure whether my last one is a comment or it's a question. There are two things from your statement. One, when the Director General was reading the last part, he spoke about, public trust and what have you. When I'm writing these stories, I'm thinking about two things. One, PMRA has to be accountable as a public institution. If you are failing, we must say so. But again, where we also sensationalize these stories, we focus on the 88%, as Jewish as it is, we could be demotivating that Malawian who wants to seek, medical help. If not, they'll go kwa singanga, and that would be undesirable. In being defensive, are you worried that these studies would demotivate health-seeking behavior among Malawians, and that's why you'd want to focus more on a rosy picture that your findings are 4% and what have you? The last one, I think, is just a comment, not necessarily a question. Thank you so much.
Thank you very much. I'll take one, the first question, and the other one that involves the medicines recall. I'll ask the Chief Medicines Inspector to explain. On the last one, accountability, I'll ask the Minister of Health also to comment. So you're very right that the statement makes reference of first a WHO prevalence rate around 10%. Second, it says based on the information that we have in our database, we are hanging around 4%. But you are recalling very well that there was a study by CUHES that reported somewhere around 14%. But I just want to add, on the basis of our reservation on the CUHES study, on the basis of the reservations that we expressed to CUHES, which we also wrote them formally, the sampling was the least on the list, was the least concerning. If you had the chance to look at the report that we availed CUHES, our biggest problem was actually how they handled the method itself. And we had several meetings with them, we have engaged with them. I think we're coming to some sort of an agreement somehow, but we expressed our reservation on the method. That was the biggest concern that we had. In our view, it should have been lower than 14%. But CUHES is just doing its job to do research. We are also doing our job to do post-market surveillance. If we disagree, we have to come together, which is what we did to discuss these things. Our view is it should have been lower than 14, in which case it would be approaching 10.5%, which is also WHO's average. In our case, in as much as our data is not collected based on research, it is a program-based data collection, it gets us to 4%. Whichever the case, we are still saying, in terms of rate of substandard products, we should be on the lower side. Whether we pick 4, whether we hang around 10.5 WHO's rates, whether we hang around 14%, which we disagree, which we think it will be lower, it is not going to be 88.4%. 88.4% is heavily exaggerated, and we want to assure Malawians today that the quality of medicines in Malawi is very well assured. The medicines are proper. But as the Minister of Health said, the problem of SF is across the globe. The running rates for low to middle income countries is around 10.5%. We don't think Malawi alone is at 8.4%. Thank you very much.
Thank you. I'll be handling the issue on recalls. So let me just give a little background when we get to the point when we are doing the product recalls. So it becomes aware and makes a decision that a product has to be recalled mainly based on 2 issues. We do conduct quality surveillance, as alluded by the DG. We've got a very well-structured program. We call it post-marketing surveillance program, which is done regularly. We go to facilities to get the samples for the quality tests. And we also get notified of the products if they are not meeting if they are substandards, warranting the recall through the complaints, quality complaints. People would complain, and we've got an investigation procedure in place where the complaint gets followed up. When we are following the complaint, the complaint institutions or individuals are told to quarantine the product. The inspectors will get the samples for the quality tests. When it has been determined and verified that indeed the product has got the issues, substandard, we proceed for the product. Now, when we come to recalling itself, we've got also a procedure. Basically, it's PMRA does the procedure with the concerned distributor, in this case, the concerned wholesaler. In case of the complaints, if it is a hospital which had complained about quality, we engage the distributor after verifying that indeed the product is of poor quality to facilitate the recall. And together we work to ensure that the product has indeed been recalled. These products are kept at the distributor level. They are kept as the quarantine as well, because the recall itself is a process. You can't just recall and proceed for disposal. The ultimate fate of the product that have been recalled due to poor standards, it's the product disposal. So the distributor would recall the product, put it under quarantine, and there is also another procedure for disposal of these products. So after the product has been recalled, it gets quarantined at the distributor warehouse, and they follow the disposal processes. So during this disposal procedure now, when we are at the point of disposing the products, the inspectors would verify those products that we've requested the concerned distributor to effect a recall, and if the quantities which were recalled are indeed matching. Because during the process, all these processes, the quarantine at the facility level, the recall process itself, we are in engagement with the concerned distributor. Documents are changed, information is changed, and at various points, inspectors would go to verify. And the final point of verification, it is at the disposal stage. So when we are at the point of disposing this product, the inspectors, together with other disposal committee, would verify the quantities that are there before proceeding to dispose the products themselves. Maybe the thing which we've been lacking is the engagement of the media. To say that when we are disposing, maybe we don't engage the media. That is one of the positive feedback which we really have to start working on it. But after recording the product, the fate becomes disposal. The other option, if there are especially private distributors, the other option is for the distributor to send back the product, the substandard product, to their own manufacturer where they had requested the product, which is deemed to be vigorous, and it would be expensive on the other part as well. So most of them, they opt to dispose the products here. But the disposal activity is well accounted for. The unfortunate part is that maybe we're not engaging the media, which going forward, it's something that we will consider. Thank you.
Nation Publications, thank you for your questions and comments as I read it. So again, I think let's go to the variations in reported prevalence rates. I think maybe sitting here this morning, we actually just take note that there is good interest in the area as reporting on falsified and substandard medicines. Indeed, so I think it is by nature in most cases when it comes to studies that they have to actually be subject to critical thinking or some criticism of sort, which is scientific, and some of the comments from PMRA would actually be based on that, but not really, again, to actually disown the fact that we have that problem. So that problem indeed is there. Like I said at the beginning, our efforts should be to contain the problem. If need be, to zero if it's achievable. But that is really a very, very hard target for even for the PMRA to achieve. But that's what we should actually be heading to. But having said that, I think one of your comments was also to say, what confidence do you really have in your initial test versus when you actually now say they are being recalled? So we have to also look at many reasons why a recall will have to come into place. So the initial test would have actually been there, it would have passed. But you see, these are products that have got to go into circulation, so they're released, they're actually on the shelf. When they're in these distribution outlets, sometimes they're handled badly, and then they do deteriorate. And that would also actually go to a reason that when they go back, they do post-marketing surveillance, because the initial test should be understood to be pre-marketing surveillance to actually release the product to the market for distribution. When it has got into distribution, it's on the shelf. They have another intervention which is called post-marketing surveillance to look at the quality of the medicines in order to give assurance. Post-marketing surveillance could actually lead to a failure of that product on quality, simply the way it was actually maybe handled. And that would actually result into a product recall. And there are different classifications of recalls, actually really demanding different kind of actions. So I will not really go into that. I think maybe it can be a subject for another day. But it's just to give confidence that indeed a test would actually be done, correctly so, and the product passed, but it fails maybe the way it was handled, and then resulting in a product recall. The other one which you have actually raised also makes sense. That indeed if there's a product recall, it should really be maybe published in a way that it definitely catches much of public attention. And the one thing that we should not really miss out is really to engage the media. As to there is a product recall here, these are the reasons, and this is what we're going to do, and they maybe also share with you the final outcome. I think is also very important, and I think we should be seen to do that. So already, I think PMRA has considered that they will have to actually improve on how product recalls are published, and as well as how we engage with the media, so that at the end of the day, the public is actually served better. My last point, I think I still go back to what Honorable Snambuli also pointed out earlier, as regards, because when we're in here, we have already highlighted that the study so much has actually really been done as antimalarials. And we have to actually also report from the point of view of Ministry of Health that there are two sources of antimalarials that's coming into the public domain. There's the public source and there's private source. We do note that most of the samples that were actually, or the study is actually reporting on, is private source. We don't want to do a disservice to the public, because we should also honor those who also support Malawi. The bulk of the antimalarials as going to antimalarial program is supported by donors through PMI, which is the US government, or Global Fund. These medicines, as I sit here, they're subjected to rigorous quality checks, including they have to pass what we call WHO pre-qualification scheme. When they come here, for most part, all of those are registered either from the supplier or manufacturer end, as well as to distribution end by the PMRA. And they are also subjected to tests as they go into public domain. The bulk of antimalarials in Malawi, they are actually from the public sources. So that we don't want to also alarm the public out there that basically the antimalarials are substandard. If they go to public source, they'll be assured to get better quality medicines. At the same time, Honorable Snambuli, you did say that there are many treatment failures. So I wanted to comment on that, that much as the substandard medicine could also indeed lead into treatment failure. But the bulk of what would also get, going by that the bulk of the medicine antimalarials are coming from at least a source that will actually assured of good quality. The bulk of the reason could also be treatment, the medicine resistance, which we call drug resistance. Antimalarials are also well known to actually suffer resistance, the more reason we change the medicines regularly. As we stand now, we're also trying to change LA to Diatep. Diatep, is that right? Yes, Diatep. For the same reason, sir. So some of the antimalarials we see that the treatment failures is the reason could also be because of resistance. So we have to also be taking note of that, but not also, I'm not really discarding the issue of substandard and phosphate medicines. We've already said it's a problem that we definitely have to be fighting all along as we go along, because that's why PMRA is created. I wanted to also at least comment on that. Thank you.
Thank you very much. I still see 2 hands. Maybe we take those 2 and then we close. If we have any more issues, we'll give an opportunity to one-on-one interviews after we have closed.
Okay, DJ, I'm Marubungira from Major FM Radio. My interest matches on the issue of 2015 report, where, among other things, it seems like the report is not giving a broader picture of the situation in the country. It's a little bit misleading. You have cited the issue of methodological limitations. I wanted to understand from your side, you have indicated that the samples that they used was from some pharmacies and some private hospitals. Have you done your research as well on malaria drugs, so that maybe Malawians could have assurance to say that the malaria drugs which are in the country are well certified and they are okay to be used? Probably others would argue to say that despite the fact that you are saying that the samples, the methodology was, there were some limitations, but then one would want to have assurance. The report definitely is unfair, probably misleading to the general public.
Okay, Robert Chandira again from Banta Synod Radio. The first question is going to the Ministry of Health. The question is, how often do you inspect the pharmacies as well as the private hospitals? Because it's like maybe if it's somewhere, somehow those inspections are not done, then it's when people may be relaxed to do whatever they can do. The second question is going to the PMRA. After looking at the findings of the research, and then you have also said you do follow all the procedures in order to monitor the supply chain for the drugs and whatsoever. Don't you think that maybe somehow, somewhere, some corruption activities are happening? Thank you.
Thank you very much. Tipeleke mpata kuti mafunso amene afunsidwawo ayankidwe.
Thank you very much. Regarding providing assurance by doing research, what we've pitched in the statement is the fact that we do not do research per se, but we have a program that whose objectives are similar to the research that we have done. Because that program is provided for in the law, is the post-market quality surveillance of medicines. So through that program, which ordinarily we do every 2 to 3 months, send inspectors, collect samples, get the lab test, get the results. We have a matrix which we use to select which products we're going to send this quarter. Through that program, we have accumulated a pool of data. Based on that data, is the one we are assured of, that it has demonstrated that the prevalence of substandard and falsified medicines in the country at the moment is hanging around 4%. As I initially said, WHO's average is about 10.5%. So we think we are still on the average that is being reported by WHO, but as the Minister of Health says, that doesn't mean that the problem has been erased. We have a problem, but not of the magnitude as reported in this study. Thank you.
Thank you for the question to Minister of Health. And it's actually bordering on inspections. So also, let's get it clear here. Pharmacy and Medicines Regulatory Authority is an agency of government for the regulation of the supply chain as it regards medicines and medical supplies. So, the inspections you are actually alluding to is also a responsibility of the PMRA, that they have to have a rigorous program of inspections or inspectorate capacity in order to contain all issues that they're supposed to regulate, including, because you actually mentioned about the issue of premises. So we have premises here which are public as well as private. All of them fall under the umbrella to actually very much inspect and actually see that they're actually within what the law is prescribing. So I know where I'm sitting that they have a regular program of inspections, but you see, like it was also pointed out by Honourable Stambuli earlier, it's all a question of capacity. See, the problem we're actually really discussing in this room is of such magnitude. This particular regulatory authority has got to have inspectors that are, as we stand, maybe sitting here now, they should be really manning the borders with maybe immigration officers and ABCD. They don't really have that. The more reason, the Director General said they have to work in collaboration with other enforcement agencies because there are limitations. But also from government side, we know that they have to really ramp up their inspector capacity if they're really to actually regulate. That I think I have to put it on the table, that basically that has got to actually happen. But it is falling in the same ambit that the government is a principal who has actually created an agency that is supposed to do the inspectorate activities in this particular cycle, and that's what they're actually really doing. Having said that, I think I should also concede here that the issue we're talking about, that the PMRA has to have room to, or has room to improve, is also very much underscored here by the fact that at the moment they are actually working with the World Health Organization on a benchmarking exercise, which actually shows that we have to improve our regulatory authority from the level 1, what it is now, to level 3 as a regulatory authority, so that at least it can actually do the job the way we need it. To do that, it needs a lot of financing, which I are also working on, and with the government we are working on, just to scope that definitely will have room for improvement. I think that's, I should also put it on the table. Thank you.
Thank you very much. We now come to the end of our press briefing this morning. Before I invite Sarah to close with a word of prayer, maybe DG, you may want to say one or two in closing.
Thank you very much. I really wish to thank you all for taking this initiative that we meet and discuss issues related to quality of medicines. This is a partnership. We are both working for the Malawi population, just making sure that they are safeguarded from any possible bad effects of medicines. I hope this engagement continues for the benefit of all Malawians. I thank you.
Director, Minister of Health, you want to say something?
Ladies and gentlemen, and in particular Honorable Stambuli, we really want to thank you for the interest you've shown in this subject matter. you are a very key stakeholder when it comes to protecting the public insofar as the undesirable effects of medicines are concerned. Government takes this particular issue seriously. The more reason, like I said, the agency like PMRA is actually created. In most cases, any regulatory authority in Malawi needs the support from the public if they are to do their job perfectly well. In this particular issue as well, it also calls for the vigilance from the public if this particular authority is going to do its job very, very well, because like I said, there are limitations. It starts with the reporting, as it has been in this case through Honorable Stambuli, to prompt the subject matter and show where we need to home in and improve more. The discussion in this room shows that we have to pay more attention to the circulation of substandard and falsified medicines. The more we have also put on the table that from the TMRI side, we have to make this engagement with the media more regular, as it would be with any other stakeholders. We actually encourage the PMRA to actually collaborate more with their other enforcement agencies insofar as porous borders are concerned. But indeed, after everything is said and done, the focus and the limelight goes on the PMRA, Ministry of Health, in order to actually really assure that the medicines that are circulating on the market are of good quality. From this morning, what we are trying to really say is we have a problem, but not to the magnitude that has actually been reported. At the same time, we also want to put on the table that from government side, through the PMRA, we are actually doing everything it can through the recommendation of the WHO on the benchmarking, that we have to improve this authority in order to actually do its job in the way we actually expect. So from this morning, as from the government side as well as PMRA, we've learned one or two things from the media. We also hope that you also actually increase this particular interest and actually maybe report so that we assure the public that it is not as bad as it has been reported. Again, Honorable Stambuli, we thank you that your prompt has made us to actually be in here in this room today, but our assurance is we'll make it more regular because we think this is where we need to correct. Whether there's a study that has actually published something, we should engage you media. Whether there's a recall, we should engage you media, because then we'll be taking the right story to the public and not to be alarmist. That said and done, again, we thank you all for coming this morning, and I also want to commend the PMRA for taking the initiative to engage you this morning, because it actually takes some other organization to do so they've done it rightly, and want to commend them. And I also want to actually thank the Central Medical Stores for coming this morning, because it is one of the major outlets for medicines. The more reason we thought they should also appear this morning. Having said that, I thank you so much for your listening.
Thank you very much. One more time, I should thank you, members of the media. You are always available when we call on you. In a special way, let me thank Zodiac Broadcasting Station for being there, making sure that the general public out there is following the proceedings of this press briefing. Thank you very much. Sarah, closing prayer, please.